Hi everyone, my name is Dr. Abdul Jabbar. I'm a medical lecturer from Faculty of Medicine and Health Sciences. I'm an anesthesiologist as well as critical care specialist from University of Malaysia Sabah. So my line of work now is currently in University of Malaysia Sabah. I'm still doing ICU round in Hospital Queen Elizabeth II, about 2 to 3 times a week. And previously, I was a TOP specialist in Hospital Queen Elizabeth and successfully procure about 4 solid organ before this and have attended countless of family counseling and rejection from the families, but that's life, right? So today I have been given the task of talking about disease donor management. So I'm doing this recording as part of the 25th annual scientific meeting of the Malaysian Society of Transplantation. So this video is for you who didn't manage to get my talk, probably because I'm talking too fast in the conference in the sake of time. And for this recording, I intend to go a bit slower so I can manage and elaborate more on each point better. Okay, so let's go. So as you all know, we are mainly talking about disease donor management. Disease donor categorized into donor after brain death, DBD, and also donor after cardiac death. Okay, so this actually disease donor management can apply to both, but we are mainly will be talking about donor after brain death, and we will discuss a lot about what happened after brain death. So if you can see here, the whole organ procurement process, it starts from donor detection and donor evaluation, brain death diagnosis, obtaining consent, and organ allocation and retrieval. And all this actually, initially the first part, the yellow part, donor detection occurs inside the ICU, or it may be outside the ICU. Usually this kind of version will be transferred to the critical care, especially usually the ICU, to carry out the further management. And then the patient will undergo donor evaluation. Then the team will evaluate the donor and also assess the organ viability to ensure whether this is a potential organ donor or not. And once the team has been satisfied and this is a potential organ donor, and the patient fulfill all the possible brain death criteria, as well as known cause of insult to the brain, and we will go towards the brain death diagnosis. And then after that, once brain death confirmed, family approach will be done, and we will let the family accept the reality of death, because this is the most important part. And for many of the normal people out there, some of them may not know or may not understand that brain death is a death. Okay, so but because culturally we have been taught and educated that death is cessation of life when the heart stops. But yeah, but brain death, this is one of the most important part. Then after that, obtaining consent, and then subsequently we will approach the patient for the family for the organ donation. Okay, after that, organ allocation will be done, and then procurement and retrieval will be done. So where does this organ donor maintenance take place? So my topic is disease donor management. So if you talk about disease donor management, there are a lot of factors, there are a lot of aspects in terms of management, like administrative aspect, medical legal aspect, the medical aspects, and what I'll be talking about today is more on the medical aspect, and about the organ donor maintenance, organ function maintenance. So organ donor maintenance, to maintain the function of the organ, actually starts right when the patient arrives in the hospital, even before the donor detection. Okay, so as soon as the patient arrives, if you detect the patient is having a potentially devastating brain injury, and the patient may become a brain dead and potential organ donor, so the resuscitation should start in the very beginning when the patient arrives in the hospital. So active donor detection in the emergency department, where the most of the source of the potential brain dead potential donor will be here, this part. So the management should start here and as early as possible. Okay, so we do not want to neglect the patient, because many a time there are a lot of cases that I have seen before, when by the time they refer to us, the management has been lacking simply because initially they thought this patient will not do well, and the patient was initially thought to be withdrawn by the neurosurgeon, by the specialist, but somehow one of the officer will say, oh, I think this is a potential donor, so let's refer to the UPO or top team. And between these 5-6 hours, because initially people thought it being withdrawal will be done, but so this hours, precious hours, may or may not be neglected. Management may be suboptimal, and this may also affect the function of the organ from hypoperfusion, okay, low BP, hypotension, and so on. Sometimes the pathological process of brain death already started when during these hours, and nobody noticed it, and this may lead to worsening of the organ function, and will worsen the outcome when the graft will be taken and transplanted into the patient later. So there are a lot of types of brain injury, CVA, brain trauma, and so on. Okay, so when we talk about brain death, brainstem death, what are the physiological changes during brainstem death? This is from Smith, when he studied thousands of potential organ donor, and brain death patient. So once brain death occur, there will be a lot of physiological changes happening. But the two main important ones are the cardiovascular disturbance, which is hypotension, as well as the diabetes insipidus. All right, so let's talk about hemodynamic instability. So right when the patient arrives, and around the time when we didn't do donor detection, these are the time that usually the cardiovascular hemodynamic instability will occur because of the presentation of the patient itself when they presented to the hospital. Okay, so hemodynamic instability in potential organ donors have plenty of etiologies. Remember, potential organ donor is also a critically ill patient, and we should treat them as if we treat any other critically ill patient when we are aiming to maintain the perfusion and hemodynamic stability. So I like this article written by Joanna K. When they are on the topic of physiological changes after brainstem death. So as you can see here, this busy slide infographic can explain on the multitudes of etiology towards hemodynamic instability in brain dead patient. So simple etiology classification based on physiological derangement includes a reduction in preload, reduced afterload, and decreased contractility. So these are the three aspects that you can think of when you talk about cardiovascular instability. manifested by hypotension, escalating vasopressor requirement, decreased SaVO2, and lactic acidosis. So factors causing cardiovascular instability in the potential organ donor. When we look at it in the reduced preload causes, a lot of causes actually, the most important cause usually in the initial phase is actual hypovolemia when the patient presented in the emergency department, and increased ICP itself, and maybe diuresis because of these causes, contrast agent, cerebral subposting, hyperglycemia, and so on. Okay, so the initial injury and the treatment given for the ICP is actually not specific for brain death. Any critically ill patient also potentially to have this. Okay, and the diuresis secondary to cerebral subposting, hyperglycemia, diabetes insipidus, hypothermia, all these may occur in any brain injured patient. Okay, so for reduced afterload, some of the things may occur specifically in brain death pathophysiology, such as catecholamine depletion, post-sympathetic surge, vasomotor center damage on foramen magnum herniation, endocrinopathy of brain death, and some may occur like systemic inflammatory response may occur in any critically ill patient. We also see this in the brain dead patient. So meanwhile, for decreased contractility, the causes listed here actually not specific for brain death. Any critically ill patient also potentially have this. So this diagram infographic is actually useful when you want to approach any critically ill patient. On top of that, it's also useful to be used when you are treating the brain dead patient. So like something like congestive heart failure, cardiac injury, metabolic disturbance, arrhythmia, all can cause decreased contractility, where you can detect it by a simple echocardiography. Talking about hemodynamic instability, because it is confounded by a lot of factors, including the initial injury, blood loss, hypovolemia, and so on. So we should talk about what is the isolated effect of just brain death alone, not including other etiologies. On this aspect, one of the landmark study done by Dmitry Novitsky is that in 1987 he did several experimental studies on chacma baboon, and this is a series of brain death studies, about three series of studies in 1987. So when he induced high intracranial pressure in chacma baboons, about 45 to 50 of them in 3 separate experiments, he want to see what are the changes, physiological changes when brain death occur. Okay, so he studied on the pulmonary edema and a lot of other hemodynamic stability, pulmonary edema, and also endocrine changes. One more. Okay, so in the experiment, Novitsky has shown that there are 2 hemodynamic phases, which is the initial sympathetic storm, where circulating catecholamine will rise up and shot up very high in the beginning, and then subsequently the body will show subsequent sympathetic loss when the catecholamine go down less and less until it becomes almost zero. Okay, so these 2 hemodynamic phases are initial sympathetic storm and also subsequently become sympathetic loss. So remember, patient's condition upon presentation also may alter or complicate or confound these phases, like comorbidities, trauma, bleeding, and others. So initial sympathetic storm occurs minutes to hours. It begins as a Cushing reflex, bradycardia, hypertension, and when the dying, pons and midbrain occur. And then it will lead to sympathetic storm, tachycardia, hypertension. When dying, which reflects the dying pons and midbrain and medulla. So eventually, loss of vagal tone will occur when medulla eventually die. And okay, so sympathetic storm occur because once the pons and midbrain die, and followed by the medulla die. When the medulla died after pons and midbrain, loss of vagal tone will occur. Unopposed sympathetic stimulation will cause this hypertension and tachycardia because of the loss of the vagal tone. So what are the effects of sympathetic storm? So sympathetic storm can cause cardiotoxicity, where sometimes it's called also called as neurogenically stunned myocardium. In the research by Nowitzki, you can see cellular and contraction band necrosis, subendocardial myocytolysis, coagulative necrosis. And if this initial sympathetic storm occur and prolong and without treatment, high incidence of graft failure can occur after transplantation. It also can cause injury to other vital organs. Sympathetic storm causing severe vasoconstriction and causing direct injury to the organ and tissue edema. So what happens next? After the sympathetic storm indicates the dying pons and midbrain and medulla. They are not died totally yet. It's like a transitional state. It's a dying brain stem. After that, when complete brain death occur and loss of sympathetic tone will occur, proceed, and it will lead to profound vasodilatation. And at the same time, the patient will have upregulation of inflammatory mediators, all the cytokines, tumor necrosis factor, and so on. So this will cause severe hypotension, reduced systemic vascular resistance, relative hypovolemia due to reduced SVR. And due to the patient presentation itself, because of bleeding, fluid restrictions, and so on, and the brain injury also at the same time, at the time of brain death, can also cause diabetes insipidus. And this severe hypotension, subsequent sympathetic loss also can cause high incidence of graft failure after transplantation. So now we know there are two distinct phases. The phase one is the sympathetic storm, and the second phase is the loss of sympathetic tone. So these two hemodynamics, the initial sympathetic storm duration can be short but injurious for the heart and other organs. Audibert et al. Define autonomic storm as systolic blood pressure more than 200 with heart rate more than 140. So this is the only definition that is available based on the current literature that we have now. Other literature does not define this very accurately like this. So I think we should follow this definition. And during this study by Audibert, he divided the patients into two groups, which is autonomic storm, which are treated AST, and autonomic storm, which are not treated ASNT, AS not treated. So when during this study between the two groups, Audibert can see the better graft function transplanted in terms of LV is EF, CKNB, and in AST group. So meaning, if the patient have autonomic storm, not all patients show autonomic storm, but if the patient have autonomic storm and treated, this will lead to better graft function, okay, in terms of left ventricle ejection fraction and also level of CKMB. And what are the treatments used in the study? In the study, they use esmolol, urapridil, nicardipine, all with a similar result. And if you read other literature also discussing the same treatment for the autonomic storm, many of the literature tend to prefer the use of esmolol, understandably because esmolol is a pure beta-1 blocker, and it's also have a very rapid offset, because we don't want this action of beta blocker to be prolonged and last well into the next phase, which is subsequent sympathetic loss. So if I want to give recommendation, we should use esmolol to treat initial sympathetic storm, because we know what happens next will be, say, subsequent sympathetic loss. So other authors suggest to treat sympathetic storm if MAP persistently more than 95 millimeter mercury. They suggest to use short-acting agents such as esmolol, GTN, and sodium nitroprusside. So like I said, I think the best one should be esmolol. So subsequent sympathetic loss, more important, this is the more important phase because it's longer. Cardiac errors can occur within hours if unsupported. Management triad consists of hypovolemia, cardiac dysfunction, and vasodilatation. So we need to tackle each of all of these issues, which usually can be seen in brain death patients. So maintenance of organ perfusion concept, you need to remember two important formula, which is the organ perfusion pressure and also oxygen delivery. So as you can see here, this is a organ delivery DO2 formula, which is a global delivery oxygen formula. As you can see here, the one part of the equation is showing the good oxygen content in the blood. This comprises of the level of hemoglobin, level of saturation of the hemoglobin, and the level of oxygenation, partial pressure oxygen in the arterial blood. Okay, so on the other side of the component of this formula is cardiac output, good pump function. So when you have a good oxygen content in blood times good cardiac output, so all the tissues in the body will have a good rate of oxygen delivery in mils per minute. So you have a good pump, but it will not mean anything if your highway or your blood vessel is not at the right size. Meaning, if the size is too big, the mean arterial pressure may drop, and the perfusion will not occur to the organ and to the tissue. Meanwhile, if the blood vessel is too constricted, the pressure will be higher and will lead to higher flow of blood to the organ. Also can be injurious. So we just need the right amount of MAP. So about more than 65 to about 90 to 95. So the higher doesn't mean better, but we just need the optimum one. So after the pumping is good, the blood vessel is good, MAP is great, and then CVP is low. So because of this pressure differential, MAP minus CVP, you can have organ perfusion pressure. So CVP must be low. Of course, if CVP is high, the gradient will not be there. Pressure differential will not be there. So organ perfusion will not occur. Okay, so as you can see here, if mean arterial pressure low, perfusion pressure is low. Perfusion pressure is low can be due to low MAP and high CVP. And like you see, if you want to resuscitate the low MAP, you can do fluid resuscitation and you can give vasoactive agent. And to avoid high central venous pressure, you need to avoid fluid overload, and you need to rule out any RV failure, and you want to avoid excessive airway pressure during ventilation in the brain dead patient. Okay, so for the management of subsequent sympathetic loss specifically in brain dead patient, so the first issue is hypovolemia. Hypovolemia can be caused by multifactorial. So the first line in many of the journal and expert recommendation is that we need to use crystalloid resuscitation. These are in line with the current practice in the ICU, where we tend to use balanced crystalloid. Okay. So beneficial like HORMONE or steroidine and so on. And second line, we can use colloid or gelatin base. However, if possible, we may not use this, but if it's really needed to maintain the blood pressure, so you may use that. Okay. So, however, colloid gelatin base can be used, but you need to avoid starch base, HAS. This has been shown in study by Chitanova et al. They have shown that higher kidney graft failure can occur if you resuscitate the patient with starch based fluid. Okay, so you want to maintain and target U volume. It's an ideal target but very arbitrary, a bit difficult because its fluid is always controversial issue. And if you are the type of person that you want to use CVP for guidance, you want to aim CVP less than 8 in general, because like I've shown before, if CVP is too high because of fluid overload or an RV failure and so on, the pressure differential for organ perfusion pressure will not be good. Okay, so how about fluid? So fluid restrictive strategy seems to benefit almost all organs, provided other hemodynamic targets are achieved. So traditionally, we are being taught that for kidney, we need to give a lot of fluids, and for lungs procurement, heart procurement, we need to restrict fluid. And what happens if you want to procure all the organs? How do you do it? So you need to be somewhere sort of in between, right? So Minambra's team have tried to answer this question, where he used fluid restrictive strategy and is actually benefit all organs having better function and graft function, less graft failure, as long as all the hemodynamic targets are achieved, like MAP, DO2, and good low lactate is low, perfusion is good, CRT is good, patient warm, peripheries, and so on. So as long as hemodynamic targets are achieved, good perfusion, there is actually no need to use liberal fluid strategy, even in targeted kidney procurement. So fluid restrictive strategy have no effect on kidney graft outcome. So do not be worried about that. So we just follow the same current ICU principle, where the in the middle is good, not too much, not too little. So how about vasodilatation problem? This is also sometimes it has been described as neurogenic shock. Okay, so something like septic shock. Okay, so vasodilatation. So the first line vasopressor will be noradrenaline. This has been extensively proven in many of the studies and research been done internationally. Because noradrenaline is a potent alpha-1 agonist, it is also by miles ahead that noradrenaline is the vasopressor of choice in many of the, I think almost all condition in the ICU. Okay, so there is a potent alpha-1 agonist and some beta-1 agonist, which of course have a best of two worlds. It's the best agent to increase mean organ perfusion pressure because it's increase the contractility, some contractility of the myocardium, as well as increase the alpha-1 agonist targeting directly on the blood vessel, increasing the mean organ perfusion pressure. So do not be afraid to use catecholamine to maintain MAP 65 to 90. If you read the older papers, you may find that some of these suggestion or recommendation is to avoid catecholamine, but this is actually not true. Okay, so when the researcher did studies again and more extensively, they found out actually the highest risk for graft failure in terms of hemodynamic management. So they have seen this a lot, especially for heart transplant. it's not the use of catecholamines leads to poor outcome. It's actually the untreated autonomic storm having the higher risk to cause graft failure for heart transplant, and not the use of catecholamine in this phase. So how about vasopressin? So if you think about brain death, of course, you may think vasopressin may be the drug of choice, because of course, diabetes insipidus is a usual findings in its patient, and when you connect the two dots, so you may think vasopressin is good, but vasopressin is supported by the large OPTN trial, but this is a non-specific observational with no proper analytical comparison, and this has been so vasopressin recommendation has come down a little bit when you read about the common consensus, expert consensus in organ donor maintenance. So some of them say it's recommended to use vasopressin, especially once the diabetes insipidus manifests. On top of the desmopressin that you want to give, you have to give, then you can also use vasopressin at the same time. And back then, before this, vasopressin was originally the first line, but nowadays, first line is noradrenaline, and second line, of course, like septic shock, vasopressin may become the second choice. So how about cardiac dysfunction? So cardiac dysfunction has multifactorial causes, and you need to correct other factors first, like hypovolemic correction, SVR correction with noradrenaline, electrolyte imbalance. Many of the time, all these factors, once corrected, will lead to a better cardiac function. And you need to optimize noradrenaline dose to improve cardiac perfusion pressure. And dobutamine next will be preferred if cardiac dysfunction still persists in this phase, in the subsequent sympathetic loss phase. But you need to remember, dobutamine may increase the myocardial oxygen demand, and we need to avoid excessive dose. We need to use the lowest possible dose. All right. Okay. So one important thing that is being repeatedly mentioned in the literature is that there is a need to delay or repeat echocardiography assessment in case deciding for heart transplant, because LV ejection fraction may be transiently poor right after the autonomic storm. Okay, so how about mechanical ventilation? Since all the brain dead patient is being intubated and ventilated, as well as specifically for lung transplantation, lung procurement. So when we talk about general goal and phases of mechanical ventilation, and there are three distinct phases when you talk about ventilator management. So the first phase is the safety phase after the patient recovering. This is normal patient, yeah, in the ICU. So the first one is safety phase, and comes after that will be the comfort phase. So when patient is starting to recover, and then patients, we are starting to wind down, and the aim of comfort will start to rise, and the safety concern will start to become lower. And then after that, in the end, we will reach the phase of liberation. And different phases have different aim, and also the aim and the technique and management. Okay, so how about if you want to know more about all these three phases, you can again, you can you can use this link. You can scan using your phone this QR code, and you can view my YouTube video on the ventilator management from this mechanical ventilation phase from minute 31 to minute 34. So for lung procurement, and as well as the other in general procurement, organ donor maintenance, lung protective strategy, yes, lung we need to do lung protective strategy, like the same thing that we do for ARDS patient. because up to 15% brain dead patient have ARDS. So, but some of them have neurogenic pulmonary edema, which is caused by autonomic storm. May or may not caused by autonomic storm, but usually will be caused by autonomic storm. Also due to pro-inflammatory release upregulation, and may be due to nosocomial pneumonia. So when you talk about safety phase, we need to make sure the driving pressure is less than 15. Driving pressure is the plateau pressure minus PEEP, and tidal volume less than 6 ml per kilo, plateau pressure of less than 30, and low auto PEEP and low mechanical power. Mechanical power is a little bit complicated, but it's okay. Most of the time we don't measure it. So other strategy that can be done is actually to use CPAP used for apnea test in case patient have worsening oxygenation, worsening lung function, and CPAP used for apnea test may also protect the lung from atelectasis and may improve the outcome, graph outcome for lung procurement. So methylprednisolone or any other steroid at 15 milligram per kilo have been shown to increase the graph function. I'll be talking about steroid, more about steroid after this. So all these lung protection strategy, CPAP used for apnea test, and steroid will improve lung transplant graft success. So let's go to electrolyte imbalance. The electrolyte imbalance, the most significant one and the most common one is hyponatremia. So during brain death, patient will develop diabetes insipidus, which is due to the loss of antidiuretic hormone, and of course due to brain infarct and ischemia. And this will lead to loss of free water, and then will cause hyponatremia. The urine will become a lot and white color, like a loss of free water in the urine. So at the same time, many doctors love to use normal saline and crystalloid containing sodium. HORMONE also already have some amount of sodium. What more if we use normal saline or 3% saline, where this may be used by the surgeon initially to counter and treat cerebral edema. So this mannitol and 3% sodium chloride contain a lot of hyponatremia, sodium, and can cause osmotic diuresis. So all three reasons also can cause polyuria. So at the same time polyuria occur, patient may have hypocalcemia, hypomagnesemia, hypokalemia, and hypophosphatemia. So basically all the electrolyte will be imbalanced and deranged. So hyponatremia is an independent negative factor for graft function, especially for liver and kidney. So how do we treat this problem? So first, we need to treat the diabetes insipidus with desmopressin. Once the diagnosis is made, so the dose will be 0.5 to 1 mic every 6 to 8 hours, or you can give 1 mic desmopressin every 12 hours. We need to titrate the dose to reduce urine output to 1 to 1.5 ml per kilo per hour. And there are a lot of recommendations to use balanced crystalloid since beginning, HORMONE and serofundin, rather than the use of normal saline. Okay, so every time we use 3% sodium chloride and mannitol, we need to use the minimum effective dose, and we need to anticipate polyuria effect and treat vigilantly by replacement of the fluid. Okay, so anticipate electrolyte imbalance, and we need to correction of electrolyte targeting normal value. So this correction of electrolyte from treatment of diabetes insipidus will concurrently help organ perfusion, and it has been shown to improve yield of organ donation, organ procurement. Okay, so we go to hormonal therapy. Desmopressin to treat the eye, yes. Steroid hormone will reduce inflammation cascade, yes. How about thyroid hormone? Okay, let's go on to steroid hormone first. So in this article, which has been cited a lot of time, more than 100 times, this is the common paper that almost all the expert consensus will cite, which is the synthesis, this review article and research by Anne Barklin. She have shown that there is a very high upregulation of systemic inflammation and release of pro-inflammatory markers cytokines in the brain dead organ donor. So brain death will cause hormonal and metabolic derangement, catecholamine storm, vasoconstriction, release of neuropeptides, secreting mediators from ischemic brain. All of these can cause inflammation in peripheral organs. So pro-inflammatory cytokines elevated like necrosis factor alpha, interleukin 1 beta, 2R, 6 and 8. This widespread inflammatory storm condition can lead to organic damage or cellular immunological changes. To make it worse, 75% of brain death patients have abrupt adrenal insufficiency. Means not only they have systemic inflammation, they also have down regulation of steroid, endogenous steroid. Okay, endogenous steroid. Okay, so this may induce an increase in this incidence of rejection phenomena because of this systemic inflammation, which can cause microvascular injuries and so on, and so increasing the graft failure. So treatment to control this widespread inflammation have shown promising results that reduce rejection of graft or failure of graft. So evidence shown it has been beneficial to be given early for hemodynamic management. Good evidence came out from corticom trial. It reduced noradrenaline dose required by 2 times lower, faster achievement of hemodynamic stability 5 times faster. Hydrocortisone that was steroid that was used in corticom trial was 50 milligram bolus, continued to 10 milligram per hour till procurement. They start giving hydrocort once after family consented for organ donation and continue until procurement. They don't give early. Yeah, they give early because they tend to take consent very early in the process. So it also has been shown to reduce rejection in liver transplant. This is study by Koch et al. RCT. So during this study, it has been given methylprednisolone 250 mg stat followed by 100 milligram per hour. It has been shown significant decrease in cytokine and adhesion molecule in hepatocytes. Other studies did not show improvement of rejection, such as study done by Kynes et al. Using 1 gram methylpred. Amaschek et al. Using 1 gram methylpred but slightly lower number of patients. So only one RCT and the other 2 RCT doesn't show any improvement of rejection. So subsequently in a 2014 systematic review by Dupois, overall quality, so it's been commented that overall quality of studies done for this particular purpose are poor. However, majority pointed towards improved donor hemodynamics, improved oxygenation status, increased organ procurement, and improved recipient and graft survival. However, it needs to be stated that overall quality of the studies done, we have shown benefits. Actually, the studies quality are poor. Okay, so we can agree, but also we need to be aware that these studies not being conducted very rigorously. But any study in brain dead patient may not have a very an ideal situation to do research. Okay, so given lack of evidence of harm and potential reduction of widespread inflammatory storms, steroids are generally recommended. So most of ALS studies use methylprednisolone at 1 gram or 15 milligram per kilo. This may exacerbate hyperglycemia and can cause higher insulin requirements. So in a pre and post study designed by Rajat Dar et al., comparing high dose versus low dose steroid, hydrocortisone 300 mg bolus continued with 100 mg TDS shown to have better glycemic control and lower insulin requirement without compromising rate of transplant rejection. Okay, so pre-study they use methylpred and post-study they use hydrocortisone. So they have shown that between methylpred and hydrocortisone, it's has been shown to have better glycemic control and lower insulin requirement. So as you can see from corticom trial, they use 50 mg hydrocort, which then lower to 10 mg per hour. So these are some recommendation that can be used, that has been used with the previous studies. So how about thyroid hormone? Again, Dmitry Nowitzki has shown in a baboon model, Chacma baboon model, that T3 depleted rapidly and body switched to anaerobic metabolism during brain death, after brain death occur. And this may be reversed with T3 administration in these Chacma baboons. So how does it translate to human studies? Okay, so unequivocal results from other studies in human have shown that it's not helpful. Others found it may reduce anatropic need and improve allogram function, but some shown it's not helpful. So this has led to Venkatesh Warren Australian intensivists to do an RCT. So it has been shown that T3 shown similar outcome in terms of anatropic support and allogram outcome. So whether you give T3 or not, it doesn't really matter. However, other studies have shown using subsequently, many studies also try to attempt to answer this, but most studies use T4 show no improvement in outcome. So you have to remember that T3 is multiple times more expensive than T4. And as a recommendation, thyroid hormone, not widely used, only for last resort in hemodynamic instability after all other management has been given. Plus, if the likelihood, and at that point of time, likelihood of high good allograft function. So next is body temperature management. When the patient becomes brain dead, patient will have this term of donor poikilothermia, which is the patient have lost of core temperature homeostasis. Hypothalamus loss from infarction will cause fall in the metabolic rate and reduce muscle activity. And peripheral vasodilatation also can occur at the same time. And so you need to monitor core body temperature continuously. And we need to institute prevention of heat loss by putting blanket forced air warmer. So on top of that, we can give warm infusion fluids, and we need to aim on normothemia if possible. One small study do indicate benefit of mild hypothermia for expanded criteria kidney allograft. So at this study, they aim around 35 degrees Celsius. So other management includes hyperglycemia, which is very common. And this is due to after brain death, in the phenomenon has been seen that there is sudden elevated insulin resistance when they notice elevated C-peptide over glucose molar ratio. And when this study has been done when they do procurement of pancreas, so they can measure directly on the pancreas for the insulin resistance. And at the same time, it has been shown that after brain death, there is reduced insulin levels production. And we also, because of hyponatremia, tend to give administration of glucose-containing fluid, which may exacerbate this hyperglycemia. And enteral feeding also will be given out of sympathy, and this also can cause hyperglycemia at the same time. So insulin will be required because you want to aim the glucose level 6 to 10 millimole per liter. This is especially important for liver allograft because it can re-glycogenate and providing fuel source during ischemia time. And this allows organ to take up glucose as fuel for metabolism. So how about internal nutrition? Conflicting recommendation by experts. Animal models using rabbit, porcine, and rats have shown enteral nutrition improve allogram function for liver and kidney. How about human study? Benefits, however, this benefits not replicated in human in randomized trial studies. Current recommendation is to stop enteral feeding. Why? Because loss of vagal tone will severely affect intestinal transit and absorption of nutrients. So because of this loss of vagal tone from the medulla which has died, the absorption of nutrient will also be affected. So gastric content, residual gastric content will be higher, and there is like potential concern on lung aspiration of the enteral feeding into the lungs. So this, when aspiration occur, this is very disastrous, can cause oxygenation and poor oxygenation and poor perfusion to the organs. And also, if you are aiming to get the lungs, procure the lung, this may not be good for the graft function. So we know glucose is needed, so we can give glucose solution, but we need to remember to give insulin as well in order to aim the glucose in the blood about 6 to 10 millimole per liter. So how about transfusion? Enough, as much as possible, we want to avoid blood transfusion because, however, we need to, we know that good perfusion also rely on a minimally required HB. So we need to give enough, just enough, maintain just enough to ensure good carrier oxygen content, maybe around 8 grams per liter. Okay, sorry, 7 grams per liter. Hemoglobin generally recommended more than 7 grams per deciliter. Higher target recommended for thoracic organs, which is more than 10 grams per deciliter. Platelet target more than 50, normal INR, PT and APTT. Aim just enough to prevent significant blood loss during procurement. This is to avoid hypoxia due to blood loss during procurement. So blood investigation, HLA typing, blood types, and viral workup need to be taken prior to any blood and blood product transfusion. This is to avoid confounding factors towards the investigation. And we want to talk about optimal time to manage. Faster procurement does means shorter time. So if we aim procurement to be fast, it will also mean there will be shorter time for donor management. This is not good for the outcome of the graft. Fast does not mean good. In a large cohort of 1,106 renal transplant recipients, longer duration of brain death was associated with improved initial graft function and graft survival. Why? Of course, when you have more time to maintain the organs, ensuring the graft function before it's being procured and undergo warm and cold ischemia time, this longer duration taken for managing the and improving the resuscitation of the patient and improving the graft function will lead to improved initial graft function and graft survival and with better outcome, suggesting that the time taken to optimize donor cardiovascular status may reduce ischemic injury. Optimal time to manage is very important. Optimize organ function first before proceeding with surgical procurement. But you need to remember, you cannot have unnecessary delay because this is very uncomfortable for the family. Communication is very important. So lastly, how about clinical provider? Managing organ maintenance is important to be done in the ICU, and it is crucial to be intensivist led. In a study done by Singh Barter, when the organ maintenance is being done by intensivists in the ICU, it has been seen that there are increase of number of organs recovered for transplantation, double the number of organs if compared to not being done by intensivists, increase in number of lungs procured triple fold, increase in number of kidneys, double, and there is a significant increase in heart and lung procurement. Summary time, start organ donor maintenance as soon as possible since identified as potential organ donor. Optimal time, take some time to aim to optimize donor physiological state prior to surgical procurement, and you may want to resuscitation and to improve the graft function. Management ideally should be done in the ICU, preferably intensively led. Hemodynamic, autonomic storm will occur first. Not all patients will have autonomic storm, but if it is present, usually around minutes to hours. The longest autonomic storm that has been seen before is about 4 to 6 hours. And if present, treat it using short-acting drug, preferably esmolol. And subsequently, there will be sympathetic loss and will cause hypotension and vasodilatation, cardiac dysfunction, and so on. So we can give fluid resuscitation, crystalloid, balanced crystalloid preferable, and subsequently we can give noradrenaline and then vasopressin, IV dobutamine if needed. Management and treatment must start early and consider etiologies contributed from presenting condition to the hospital. So we give steroids early to control inflammatory reaction, be it methylprednisolone or hydrocodone, doesn't matter. And we need to employ lung protective strategy, maintain normothermia, aim normal glycemia, about 6 to 10 millimole per liter. Most importantly, there is no I in team. Together, everyone achieves more. We need to do this donor or disease donor maintenance as a team, because there are a lot of things to do, medical, legal, medical, and so on. And thank you. Hope you enjoy the talk.